So I run the lipid clinic at UCLA, and we have about 150 people on PCSK9, but it takes one of my medical assistants about half of her time just doing prior auths. We've gotten most people approved, but the copays are variable from $40 a month up to $400 a month. So it's a challenging space right now. The biggest challenge is it does take 3 to 4 months and a lot of manpower to get it approved, and then the financial realities are that even some people who after those 4 months you get them approved, their copay is $400 and they can never afford that. What we know is diabetes is one of the most potent risk factors for cardiovascular disease. And what we've known for years in the preventive cardiology program is that risk factor modification is the key. It underlies everything we do. And we've done a great job with lipids and statins, now PCSK9 inhibitors. We've done a great job with blood pressure. The one little nut we never could crack was diabetes, because there are so many diabetes drugs out there, and there's so many good effects on lowering glycemia, perhaps preventing microvascular disease, but we've never been able to get a reduction in macrovascular disease. So the cardiovascular diseases that kill most of our patients, or cardiovascular death, we haven't had a lot of luck until recently. We've had some drugs in the diabetes space that can do that. So empagliflozin was the first one to get the FDA approval for reduction in cardiovascular death. That was based on the EMPA-REG trial. Liraglutide is about to get the same FDA approval for reduction in cardiovascular events, I believe, although it's only at the subcommittee level right now. The FDA has not yet voted, but it looks like they'll get that as well, and we'll see what else comes down the pike. Well, so the first one, empagliflozin, is an SGLT2 inhibitor, a unique mechanism of lowering glucose. Liraglutide is a GLP-1 receptor agonist, which is another incretin that works to lower glycemia. And interestingly, both of these drugs, and in fact all of these drugs in this space, were mandated by the FDA to do cardiovascular outcomes trial after the drugs were approved based on glycemia alone. So they said, okay, we'll give you approval based on how well you can lower A1C, but then we want to make sure that these drugs are safe, so you have to do large-scale cardiovascular outcomes trials, and all we ask is that you have to prove that there's no harm. So these were non-inferiority studies. You had to prove they weren't worse than placebo. And then we were really lucky and surprised when some of them started coming out positive. There were some others that were completed before that were neutral, which was non-inferior, which was good. But then we started seeing positivity, which is, I was as excited about that as I was about some of the statin trials.